This brief talk will cover some introductory topics related to invasive ventilation, which is something that if you're new to critical care you may not have come across before. It can be quite intimidating being faced with a patient on a ventilator and being asked questions about what you want to do and what management you want to change. I'm not going to be able to cover everything in this talk. This is just an introduction into some of the principles around why we do some of the things we do, and introduce you to some of the language that you'll hear on the unit. So there's different modes of ventilation. This is kind of divided at the very top by invasive and non-invasive. So invasive obviously requires a tube into the trachea. Now this is commonly a cuffed oral endotracheal tube, but it may also be a tracheostomy. Non-invasive ventilation, as we use it on critical care, would tend to be either a face mask that's a full tight-fitting face mask, or a what's called a helmet or the hood, which is essentially a big bubble over the patient's head. Now, controlled or assisted ventilation. So in controlled ventilation, the ventilator is breathing for the patient, and this is often the patient will be apneic, either due to sedation, paralysis, or just their disease state. So the ventilator breathes for them. Probably the most common mode is an assist mode. Now, most of the patients you'll see who are intubated will be breathing for themselves, but they will be getting some help from the ventilator. And again, we can talk about that more in a minute. And then the way that you control the ventilation, is it a volume or a pressure control? So volume control ventilation, we're setting a tidal volume and we're setting a respiratory rate, and it will deliver that tidal volume that many times per minute. Whereas pressure controlled, you're setting a pressure and the ventilator will deliver that pressure a certain number of times per minute. So in pressure, the volume that the patient receives is determined by their respiratory compliance, whereas in volume control, the pressure that the patient experiences is determined by the respiratory compliance. And then pressure support. So often you'll hear us talk about CPAP pressure support, and this confusingly is very different to CPAP via a face mask. CPAP via a face mask is just a constant airway pressure, so it's like sticking your head out of a car window, whereas CPAP pressure support is more like the sort of NIV BiPAP type mode that you'd see used in COPD, for example, where there'll be a continuous airway pressure, which we would call the PEEP, or the positive end expiratory pressure, and then when the patient takes a breath, there will be an assist pressure or pressure support. So you might hear us talk about the patient's on 5 and 5, which would be 5 of PEEP and 5 of pressure support. So when the patient takes a breath, they're experiencing 5 centimetres of water delivered above the 5 centimetres of water of PEEP. There are lots of settings on a ventilator, and it can be a bit confusing when you first start, but obviously the most easy to understand is the FiO2, or the fraction of inspired oxygen. How much oxygen are we giving? How much oxygen are we giving that patient? Then the P-insp, or the inspiratory pressure. So if we're set on a pressure control mode, then this is the pressure we're setting to deliver the breath. Pressure support, so when the patient takes a breath, how much extra pressure is the ventilator going to give them? Volume, self-explanatory really, is the tidal volume that we're setting. PEEP, or positive end expiratory pressure, is a pressure that's present throughout the respiratory cycle and helps prevent airway and alveolar collapse. The respiratory rate obviously is how many times per minute the breath is being delivered. And then the T-insp, or inspiratory time, is the time over which that breath is delivered. And this is important when we're thinking about the IE ratio, or the inspiratory-expiratory ratio, because there may be patients that we want to allow a shorter inspiratory time and a longer expiratory time, or increase the IE ratio. So for example, an asthmatic with bronchospasm, they need time to exhale to let that air out of their chest. ARDSNet was a sort of seminal paper published in the critical care literature in 2001, where it showed that lung protective ventilation dramatically improved mortality. So if you're using ventilation of 6 to 8 mils per kilo of ideal body weight, then you're doing okay. So in general, what we would do is we would do a lung protective ventilation strategy, which in general works out that you can use a volume of 400 mils for females and a volume of 450 mils for males. And that will usually be about right, unless they're at the extremes of body size. We're going to set a respiratory rate, and again, we're going to be careful about how high this rate goes, because as we're delivering the breath with positive pressure and the patient is exhaling passively, if we don't allow enough expiratory time, so therefore if we set a too high a rate, the patient won't have time to empty their chest before the next breath is delivered, and therefore they will breath stack, which is where you get a breath delivered before the chest is empty, and gradually over time the pressure in the chest will increase to such a point that it can cause complications such as pneumothorax, barotrauma, or cardiovascular collapse from a sort of tension pneumothorax type physiology that will develop. Then you're going to increase the PEEP according to the FiO2 that you're using. ARDSNet very helpfully provided a PEEP titration table, which I'll show you shortly. And what's important is we need to control the plateau pressure. So the plateau pressure is the pressure within the lung when inspiration has ended, so when the chest is full and movement has stopped. And if you keep this pressure less than 30, that would be considered lung protective. If it's consistently over that, you're going to risk causing problems. And again, we're going to kind of ignore the CO2 while the pH is over 7.32, because we're more interested in protecting the lungs and not causing damage than we are in normalizing all the numbers. The reason PEEP's important is because it helps keep your lungs inflated. If you imagine a balloon, when the balloon is empty, it takes a lot of pressure, a lot of effort to inflate that balloon. Whereas if you put a bit of air in the balloon, it's much easier to inflate from that point. So it's just simple physics, and that's why we like PEEP, because it helps keeps the lungs open and ready to receive that breath, and therefore improve the compliance. So this is the PEEP titration table from the ARDSNet paper. As you can see, they go up to very high levels of PEEP, even up to 24, which would not be a common situation that you would see very often. Now, the ventilator will give you the P peak, or the peak pressure. It will show that on the screen, whereas a plateau pressure you have to measure by doing an inspiratory hold. Now, a peak pressure is the resistive pressure. So this is the pressure that you're having to exert in order to blow up the balloon. So it's the maximum pressure experienced by the proximal airways. So it's really representing the pressure that your larger airways is receiving. So if you have a problem with your larger airways, your airway compliance at that point is going to be massively decreased and your peak pressure will go up. So if you have bronchospasm, if you have secretions or mucus plugs blocking off your larger airways, or if your endotracheal tube is blocked, your peak pressures will be very high. The plateau pressure is the elastic pressure. So this is the pressure that you need to keep the balloon open once inspiration has happened. So it's the end inspiratory alveolar pressure. And we measure that by doing an inspiratory hold on the ventilator. It won't just display the number. And it will always be lower than your peak pressure, and it's related to your airway compliance only. So this could be affected by the presence of a pneumothorax or problems with the lung itself, such as pulmonary edema, ARDS, or pneumonia. And it's what we're really interested in when we're looking at lung protection. So just to discuss through a case, we have a 40-year-old patient who's previously fit and well, and he's been admitted with pneumonia and intubated on critical care, and a blood gas is performed. So as we can see, his pH is 7.4, which is normal. His CO2 is 5, his PO2 is 7, bicarb is 22, base is -2, and lactate is 1.2. So what else would you like to know, and what ventilator settings will you change? Well, crucially, first of all, we can see that the PO2 is 7. So this is obviously low. So we would want to know how much oxygen is on, what his saturations are, and whether there's any scope to increase his oxygen, inspired oxygen, to improve that, because he is hypoxic. What sticks out to me as well is it's unusual to see a patient who's intubated with a normal CO2 and a normal pH. So I want to make sure that we're not ventilating him too hard. So I'd be looking at his respiratory rate, his tidal volumes, measuring his plateau pressure, making sure that's not too high, and probably easing back off a little bit on the ventilation once I've fixed the oxygenation issue, just to make sure that we're not causing any ventilator-induced lung injury. Now, which settings can we change to improve oxygenation? And the short answer is all of them. FiO2, so obviously we can increase the amount of oxygen we're giving, which will fix things to a certain extent. The problem with that is that oxygen is directly toxic to lungs in high concentrations. So if you're ventilating someone on 100% oxygen for a long time, hours to days, you're going to cause significant problems in their lungs. Inspiratory pressure, so if they're on a pressure control mode, we can increase the inspiratory pressure to get larger volumes, which will help re-inflate the lungs and may help deliver the ventilation more effectively and improve oxygenation. If they're breathing spontaneously on a CPAP pressure support mode, we could increase the pressure support to get larger volumes if volumes are an issue. And similarly on volume control ventilation, or SIMV, as we tend to refer to it, which is synchronized intermittent mandatory ventilation, we can change the volume. The most common thing we would do though is fiddle with the PEEP to make sure that we're maintaining the lungs in an inflated state, so that the next breath is delivered more effectively, and we're increasing the patient's functional residual capacity, and that oxygen storage they have in their lungs is being adequately used. Respiratory rate, obviously if you're not ventilating someone quick enough and they have massive oxygen consumption, you're not delivering enough oxygen and that can lead to problems. That would be unusual though to be a reason why someone would be hypoxic, unless you're only ventilating them once or twice a minute. And then your respiratory time, so we can adjust the IE ratio to improve oxygenation, and we can do what's called inverse ventilation, which again is not commonly done, but you can do it. And what this means is you're doing a very prolonged inspiratory time and a very short expiration. And this prolonged inspiratory time is a bit like blowing a balloon up very slowly, in which case you can gradually increase the balloon stretch and distribute the ventilation more evenly and improve lung recruitment. But do we really care about the PaO2? And this is an important point, because actually if you look at how the oxygen is carried in the blood, if you multiply your saturations as a fraction times your hemoglobin by Huffner's constant, which is 1.34, this will give you the amount in mils that your hemoglobin is carrying. Whereas if you multiply your PaO2 by 0.023, this will give you the amount of oxygen in milliliters that is dissolved in the blood. And you will find that the amount of oxygen bound to hemoglobin is orders of magnitude bigger than that which is dissolved in the blood. And what we're measuring with a blood gas is the amount of oxygen that's dissolved. So to me, if the PaO2 is 7 but the SATs are 94, I'm going to be fairly happy to manage the patient based on their oxygen saturations. So the same patient, but now pH is 7.1, CO2 is 8, PaO2 is still 7, and the other things are unchanged. So again, the oxygenation here is still an issue. We don't know the oxygen saturations, but it's still not good. But we can see they've got quite a significant respiratory acidosis with the high CO2. So not only are we not oxygenating them properly, we're not ventilating them properly either. So we need to make some changes to make that better. And again, how do we improve CO2 removal? Well, adjusting the FiO2 won't make a difference. We need to optimize their minute ventilation, which is their volume, the tidal volume multiplied by their respiratory rate. So if they're on a pressure mode, we might want to increase the inspiratory pressure. If they're on a volume mode, we might want to increase the volumes. If they're on a pressure support mode, we would increase the pressure support. This is assuming, of course, that we're not exceeding lung protective targets with the ventilation. Adjusting PEEP will have minimal effect on CO2 removal, apart from allowing lung units to be recruited to allow them to take part in ventilation. The mainstay really of adjusting CO2 removal is the respiratory rate, adjusting that and making sure that you adjust your inspiratory time to maintain an IE ratio of about 1 to 2. Because as you increase the respiratory rate, if you don't reduce the inspiratory time, you'll notice that the IE ratio will go a bit haywire. So how do we improve oxygenation in ventilated patients? Well, there's kind of a stepwise approach to managing this. And the first thing we're going to start with really is we're going to fiddle with the ventilator. So we're going to increase the FiO2. We're going to make sure the tidal volume is optimized. We're going to increase the PEEP and alter the IE ratios to ensure that we're delivering the breath in the most effective way possible. We're also going to then assess the patient to make sure that they don't have lobar collapse that needs a bronchoscopy, make sure they don't have frank pulmonary edema that we can treat, make sure there's not a pneumothorax. These are all things that we can fix. We also want to make sure they're well sedated and compliant with the ventilation. If all that's happened and we're still struggling, there's a few other things we can try. So we could try airway pressure release ventilation, or APRV, and this is kind of an extreme form of inverse ratio ventilation, which I'll show you a slide about shortly. You can also use inhaled nitric oxide, and what that does is it will cause pulmonary vasodilation from within the alveoli where the nitrous oxide releases, therefore allowing more blood flow to ventilated areas of the lungs, and that will improve your oxygenation. You can also use inhaled prostaglandins, such as iloprost, which will do largely the same thing. Muscle relaxation, so if you're really struggling with ventilation, we're going to make sure the patient is well sedated, and then we're going to paralyze them. And we would tend to use atracurium and then run an atracurium infusion. And whilst we're doing that, we would use a BIS monitor, which is something that sticks onto the patient's forehead and gives us a bispectral index number, which shows us that the patient's asleep. Because obviously being awake and paralysed is no fun at all. Prone positioning is something we do an awful lot ever since it worked so well in COVID, so we're very quick to use that now because it does work. High frequency oscillation is historical now. We don't use that. We don't even have an oscillator anymore. But that was a sort of where the patient's chest would be inflated with the pressure, and then there would be an oscillatory ventilation at sort of 5 hertz to oscillate the patient's chest. And it did improve oxygenation, but it also caused a lot of lung damage and actually was shown to cause harm in some major trials. And then the final step really is ECMO. It's something that's been used more and more, but they do have tight selection criteria. So again, the majority of our patients actually will not make it to ECMO because they'll either be not well enough for transfer or they'll be declined based on comorbidities, age, or length of ventilation they've already had. So proning, how does it work? Well, if you're supine, you're perfusing your less well ventilated alveoli. And this is just due to gravity. So when you're sitting upright, the bases of your lungs are the lowest and therefore get the most blood flow, whereas the apices of your lungs get the least blood flow just because the blood has to travel higher. But due to the compliance of the lungs in different areas, the tops of your lungs tend to get the best ventilation. And this obviously is a bit of a ventilation perfusion mismatch. Now in health, this isn't a big deal. This doesn't cause any problems in health, but when you're critically ill with pneumonia and areas of the lung aren't working, this becomes more of a problem. And therefore, if you're ventilating areas of the lungs that aren't perfused, or you're perfusing areas of the lungs that aren't ventilated, it doesn't matter how much oxygen you give, it's not going to get into the blood. And the way these 3 zones of the lungs are described, they're called West zones. The other thing we can't tell really is what's happening to the lungs from when we're ventilating them. What's happening on a biological level because of the pressure we're putting into the chest. the sort of barotrauma where the lungs are being overpressured, or the atelecta trauma where the lungs are collapsing and re-expanding again and again. This is all causing damage. And similarly with high amounts of oxygen, you're going to generate free radicals, and that's going to damage your lungs, which we can't measure any of this. So this is all just things we need to think about. But prone positioning is very useful. And the reason it's useful is because it alters the pressure gradient in the lungs, because you're lying on your chest, and the larger portions of your lungs are posterior, because the heart is an anterior structure, so that takes up some space in the chest. So when you lay the patient prone, the posterior portions of the lungs, or the sort of dorsal portions of the lungs, suddenly aren't squished by all the stuff in your chest, so they can expand more effectively. Similarly, the anterior portions of the lungs, when you've been ventilated for a few days, often these will be quite damaged from high pressure ventilation. So what you're doing is you're switching to an area of the lung that's been ventilated less, and so hopefully should work better. And the benefit of all this is you're improving your ventilation perfusion mismatch. It also displaces the weight of the abdomen off the diaphragm. It displaces the pressure from the chest on the right ventricle, so it all optimizes lung expansion and pulmonary perfusion. And similarly, because all the bronchi tend to kind of point anteriorly, this will improve your drainage of the bronchi and increase secretion clearance, therefore clearing the airways better. So you often see a very dramatic, very rapid improvement in a severely hypoxic patient when you prone them. The important thing with proning is that it has to be done safely. So you need a team of people. You need a checklist to make sure you've got all the things you need and the patient's stable and ready to go. And the patient needs to be well sedated and often paralysed to make this safe. So it's something we do use quite commonly, and it's something that definitely is of benefit. There's good evidence from randomised controlled trials that this decreases mortality compared to other manoeuvres. APRV, there's different thoughts about APRV. Some people like it, some people don't. Some people think you should just get on and prone the patient if you're at a point where you're using APRV. The benefit of APRV is it's something else to try that doesn't involve moving the patient. So if you've got someone that you really don't want to prone, if they've got an unstable spinal fracture, for example, or they're morbidly obese and moving them is going to be very difficult, this might be something you try before doing that. Essentially, it's bilevel airway pressure. So you've got a high amount of PEEP and a high inspiratory pressure, but the difference is that the inspiratory pressure is held for a long time. So the upper pressure was called your P high, and then your P low would usually be set at 0. But the theory is that you never reach your P low, because when you let the patient exhale, that exhalation time is very, very short, and you only let their lung empty to about 75% of its volume before reinflating it. So although the 0 pressure is the baseline, the patient never reaches that. So the idea is it attempts to keep all alveoli recruited. And actually patients can breathe spontaneously over the top of this. And it seems to be tolerated relatively well. So how to set it up? Well, initially, the guidance is that you set your P high to about your plateau pressure or slightly less. And your P low would usually be 0. Your T high would be the time that the patient spends at that higher pressure, and this would basically be about 6 seconds. The shorter the T high, the more releases you're going to get in a minute, and therefore the more ventilation you're going to get. So this would mean that you're going to increase your CO2 clearance if that becomes an issue. And your T low is how long you let the patient exhale for. And essentially, we never ever want this to get to 0. And our ventilators now can do auto flow, so it will calculate it for you and make sure the exhalation time is adequate, and it will adjust it automatically. So if we want to improve the patient's oxygenation, we're going to increase your P high, we're going to increase your T high. So we're going to give more pressure for a longer time, and then we're going to decrease your T low. So therefore decrease the amount of time that your patient is exhaling for, and the lungs are potentially collapsing during that. If we need to improve the CO2 clearance, we can increase the P high, because that's going to increase lung expansion. And then you can it says increase here, but you can decrease your T high, because that will allow more airway releases. Weaning APRV, there are two options really when a patient improves. You can either switch them back to conventional ventilation, or you can so-called drop and stretch. So this would be where you sequentially decrease your P high and increase your T high gradually. So what you tend to get towards is a lower pressure for a longer time. So it almost becomes like a CPAP type mode. And when you get to that point, you can switch them to CPAP pressure support. We tend not to do this very often. It's very difficult to do. Some units do this very well. We would tend just to switch back to conventional ventilation or CPAP pressure support.